Femoroacetabular impingement. Femoroacetabular impingement is a well-described pathologic condition that can lead to painful cartilage injury, labral tears, and arthritis. Impingement can occur as a result of femoral-sided impingement, known as cam impingement, acetabular rim impingement, also known as pincer impingement, or a combination of both. The pincer-type lesion refers to the overcoverage of the acetabulum. In high degrees of flexion, the pincer lesion repetitively hits the femoral neck, resulting in degeneration, ossification, and tears of the antero-superior labrum. Cam lesions of the femoral neck impinge against the acetabular rim. This can lead to cartilage injury within the acetabulum. This differs from pincer lesions where the acetabular labrum tends to fail first, oftentimes leading to degeneration and eventual ossification of the labrum. In the majority of cases, there is a combination of cam and pincer impingement. The combination may lead to labral degeneration and ultimately cartilage delamination within the joint. Arthroscopic approaches to impingement surgery can typically be performed through 2 to 3 standard entry portals. There is a thick muscular and capsular envelope surrounding the hip joint. 2 primary hip flexors, the rectus femoris and the psoas tendon, cross the hip joint and are subject to inflammation and tendinitis as a result of surgical intervention. Arthroscopic impingement surgery requires axial distraction of the joint. The traction that is applied provides space between the femoral head and acetabulum. This allows for access to the hip joint and treatment of the labral pathology and the rim impingement. The initial part of the surgery requires debridement of any non-viable labral tissue. The decision to remove labral tissue is based upon the location, chronicity, and vascularity of the injured fibrocartilage. Attempts are made to preserve as much healthy labral tissue as possible. Once the labrum is debrided, the pincer lesion is visualized and resected using a motorized burr. Intraoperative fluoroscopy is often used to assist in determining the extent of bony resection. Once the rim impingement lesion is removed, the viable labral tissue is refixed to the rim of the acetabulum. Suture anchors are placed in the rim of the acetabulum. Once the anchors are placed, the suture material is passed from the base to the tip of the labrum. This helps to avoid exposing the suture to the cartilage of the joint. After the labrum is refixed, the traction is released and the femoral head is brought back into the acetabulum. The hip is flexed to approximately 30 degrees. This relaxes the capsule and helps to fully visualize the cam lesion in the periphery of the joint. The cam lesion is removed from the femur. This is done to restore the normal sphericity of the femoral head. Fluoroscopic and arthroscopic visualization helps to recreate the normal offset. At the completion of the resection, the hip is moved around to confirm that the impingement lesions have been removed. Patients are allowed to leave the hospital the same day as the surgery. Most patients return to full, unrestricted play within 4 to 6 months of supervised therapy. Crutch time ranges from 2 to 4 weeks.